Hey everyone, welcome back. So far we have been talking about different classification of anemia, and today in this video we will see some other causes of anemia. The first one that we are going to see is sideroblastic anemia. Sideroblastic anemia is a microcytic anemia caused by a disorder in the synthase of hemoglobin, and it's characterized by trapped iron in the mitochondria of nucleated RBCs. Normally hemoglobin is produced from heme and globin, and heme is composed of a ring-like compound known as porphyrin, and iron will attach to it inside the mitochondria. Before we jump into the disorder directly, let's see the normal synthesis of heme. The production of protoporphyrin starts with glycine and succinyl-CoA, and these two compounds change into ALA or aminolevulinic acid by ALAS or aminolevulinic acid synthase, which is the rate-limiting enzyme. And this enzyme also uses vitamin B6 as a cofactor. And then this ALA change into porphobilinogen by ALAT or aminolevulinic acid dehydratase. And after passing a couple of reactions, at last protoporphyrin will be formed, and it will bind with iron inside the mitochondria by the enzyme called ferrochelatase. And these two enzymes, or ALAT and ferrochelatase, can be inhibited by lead. When it comes to the causes, there are hereditary and acquired forms. The hereditary form is from either a defect in aminolevulinic acid synthase or ALAS, or an abnormality in the vitamin B6 metabolism, while the acquired form are from drugs such as chloramphenicol, which affect ferrochelatase activity, or it can be from isoniazid and alcohol, which leads to vitamin B6 deficiency. And as we discussed earlier, vitamin B6 is a cofactor in the formation of aminolevulinic acid. The other acquired cause of sideroblastic anemia is lead poisoning. Lead inhibits the body's ability to make hemoglobin by interfering with several enzymatic processes. Specifically, it inhibits aminolevulinic acid dehydratase or ALAT and ferrochelatase. And sideroblastic anemia may also progress to acute myelogenous leukemia or AML in small amount of patients. When it comes to the clinical presentation, the symptoms are related to the severity of the anemia, and there is no specific finding that will be suggestive enough to make a diagnosis without specific laboratory evaluation. And the diagnosis include elevated serum ferritin level, very high transferrin saturation, and very low TIBC or total iron binding capacity. If there is already sufficient amount of iron in the serum, there is no need of having additional iron in the blood, so the binding capacity will be low. The serum iron level will be also high, and these findings sometimes resemble with hemochromatosis or an iron overload state. But the most specific test is a partial blue stain of RBC in the marrow, which will reveal the ring sideroblast. As we mentioned earlier, the binding of protoporphyrin and iron take place inside the mitochondria, but since there is no sufficient protoporphyrin, the iron will remain trapped inside the mitochondria, and the mitochondrial fount surrounding the nucleus, so it will cause a ring appearance, as we can see in the picture. And marrow reticuloendothelial iron or stored iron is also increased since the iron is not used. And it's important to remember that sideroblastic anemia is the only microcytic anemia in which serum iron is elevated. As we discussed earlier in the previous video, in other type of microcytic anemia, serum iron is low. The other type of anemia is paroxysmal nocturnal hemoglobinuria or PNH. Before getting into technical definition, let's see the literal definition first. Paroxysmal means sudden severe attack or a sudden increase in intensity of a disease, and nocturnal means dawn, occurring or active at night, and hemoglobinuria means hemoglobin in urine. So paroxysmal nocturnal hemoglobinuria is a sudden severe attack towards hemoglobin at night. It can also be described as a red cell membrane defect leading to intermittent dark urine and venous thrombosis, and it's a chronic form of hemolysis. When it comes to the pathogenesis, it's a red cell membrane defect in phosphatidylinositol-glycan A or PIGA, allows increased binding of complement to the red cell, leading to increased intravascular hemolysis, which is exhibited at night. This hemolytic episode occurs only at night because everyone becomes a little acidotic at night because of relative hypoventilation, And this acidic environment activates the complements and the cell are more susceptible to lysis. And since this disorder is a clonal stem cell disorder, it can also develop into aplastic anemia and leukemia as well. When we see the clinical presentation, in addition to the symptom of anemia, these patients characteristically present with dark urine from intravascular hemolysis, and there is also thrombosis of major venous structure, particularly the hepatic vein, and this disorder is called Budd-Chiari syndrome, and it's a common cause of death in these patients. When the hemoglobinuria is most commonly occur in the first morning urine, because the hemolysis occur most often when patients develop a mild acidosis at night. When it comes to the diagnosis, besides the usual lab finding of hemolysis such as increased LDH, bilirubin, and reticulocyte count, these patients have brisk intravascular hemolysis and therefore they have low haptoglobin. Haptoglobin is a protein that binds to free hemoglobin. So as the free hemoglobin increased, the free haptoglobin will decrease since it binds with the hemoglobin. So these patients have reduced free hemoglobin amount, and hemoglobin in urine is also found in these patients. And the other one is hemosideruria occur when the capacity of renal tubular cell to absorb and metabolize the hemoglobin is overwhelmed, and the slough of iron-laden cell are found in the urine. The gold standard test is flow cytometry for CD55 and CD59. They are cell markers on white and red cells in PNH. These levels are low and even absent sometimes. The other disorder related with anemia is chronic renal failure. Chronic renal failure, whatever its causes, almost invariably associated with anemia that tend to roughly proportional to the severity of uremia. The base of anemia in renal failure is multifactorial, but the dominant cause is the diminished synthase of erythropoietin or EPO by the damaged kidney, which leads to inadequate red cell production. Other causes of anemia in these patients include blood loss from hemodialysis or a low level of nutrient found in food, or extracorpuscular defect that reduce red cell lifespan, iron deficiency due to platelet dysfunction, and increased bleeding, which often encounter in uremia. Also can be other contributors. Administration of recombinant erythropoietin results in a significant improvement of the anemia, although an optimal response may require concomitant iron replacement therapy. The other disorder that's related with anemia is hepatocellular liver disease. Whether it's toxic, infectious, or cirrhotic, hepatocellular liver disease is mostly associated with anemia, attributed to a decreased marrow function, but it's multifactorial. Common causes include acute and chronic blood loss due to upper GI bleeding or gastrointestinal bleeding, malnutrition, vitamin B6 and folate deficiency due to poor oral intake and intestinal malabsorption, hypersplenism secondary to portal hypertension, and enlarged spleen can reduce the number of healthy red blood cells and platelets in the bloodstream. And the other is impaired coagulation due to decreased production of coagulation factor, and earlier we said hypersplenism cause decreased platelet amount, so blood won't be clotted easily. Alcohol causes anemia by its direct bone marrow toxicity, and also treatment related anemia in patients with chronic hepatitis C virus infection receiving ribavirin and interferon. Hepatitis associated aplastic anemia characterized by pancytopenia and hypocellular bone marrow, and this is an entity seen concurrently with or within 6 months of infection with hepatotrophic viruses such as hepatitis B, hepatitis C, and Epstein-Barr virus. In liver failure, erythroid progenitors are preferentially affected, but depression of the white cell count and platelet is less common, but it might also occur. And the anemia is often slightly macrocytic due to lipid abnormality associated with the liver failure, which causes red cell membrane to acquire phospholipid and cholesterol as they circulate in the peripheral blood. But it might also be normocytic normochromic or microcytic hypochromic in cirrhosis-related iron deficiency anemia and anemia of chronic disease. The other disorder that can cause anemia is endocrine disorder, particularly hypothyroidism. Hypothyroidism may be associated with mild normocytic normochromic anemia. Thyroid hormone stimulates the proliferation of erythrocyte precursor both directly or via erythropoietin production enhancement. Anemia in hypothyroidism might result from bone marrow depression, decreased erythropoietin production, comorbid disease, or concomitant iron, vitamin B12, or folate deficiency, and altered iron metabolism. And oxidative stress may also contribute to anemia in hypothyroidism. To summarize, sideroblastic anemia is a microcytic anemia caused by a disorder in the synthase of hemoglobin, which is characterized by trapped iron in the mitochondrial nucleated RBCs. There are both hereditary and acquired forms. Hereditary in the defect in ALAS or ALS synthase, or acquired forms in drugs such as chloramphenicol, isoniazid, and alcohol. And sideroblastic anemia is the only microcytic anemia in which serum iron is elevated. Paroxysmal Nocturnal Hemoglobinuria is a red cell membrane defect leading to intermittent dark urine and venous thrombosis. Thrombosis of major venous structure, particularly the hepatic vein or bad syndrome, is a common cause of death in these patients. The golden standard test to diagnose PNH or paroxysmal nocturnal hemoglobinuria is flow cytometry for CD55 and CD59 on white and red cells. Chronic renal failure is almost invariably associated with anemia that tend to be roughly proportional to the severity of the uremia. The base of anemia in renal failure is multifactorial, but the dominant cause is the diminished synthase of erythropoietin. Hepatocellular liver disease is associated with anemia attributed to decreased marrow function, and folate and iron deficiency anemia caused by poor nutrition and excessive bleeding often exacerbated anemia in this setting. The anemia is often slightly macrocytic due to lipid abnormality, but it might also be normocytic normochromic or microcytic hypochromic in cirrhosis-related iron deficiency anemia and anemia of chronic disease. Endocrine disorder, particularly hypothyroidism, may also be associated with a mild normocytic normochromic anemia. Thanks for watching. If you like this video, please like and subscribe for more.